Okay, Assalamualaikum everyone. Good afternoon. Now we are continuing our visual pathway lecture. I would like to bring your attention to this picture again, even though we have gone through it before. Just one more thing that I would like to tell you. You remember the photoreceptor just now? Okay, it starts from the cone going up, and it's like a layer cake down here. So only the top one, the most superficial is the retinal nerve fiber layer, and then it went into the optic disc. It's actually there's a empty space here. It's just for laluan, just for laluan for the retina. In a bundle, it becomes an optic nerve. So therefore, the rest of the retina here has rods and cones. Except for the part at where the optic nerve is. You get it? You understand? Because the optic nerve is just basically just a bundle of this. Echo the tail of the ganglion cell, which is called the retinal nerve fiber layer. So therefore, this part has no photoreceptor. Okay, so this is that's why it's called blind spot. Okay, at this place, the eye cannot see anything. It's called the blind spot. All right, and then we go back to the visual field again, which has this reverse relationship. Okay, and then we go back to this picture again. Okay, this is just a summary of this. Okay, all right. So now we go on how to roughly do visual field confrontation. Confrontation visual field. Okay, so okay, that's a simple way, and that's an exam way, the medical student way. The simple way is whereby you sit in front of the patient like this, same level and arm length, and then close the left eye of the patient, and then examiner close his right eye, okay, and then fixate steadily at the examiner's eye, and then you test the quadrant by you test the quadrant, you divide the field into 4, and then you just roughly ask the patient to read your fingers at the 4 quadrant. Okay, this is the crude way of doing a visual field. Okay, like a fast way. When you are in a clinic, you want to be fast, roughly. Okay, you just sit in front of the patient. You divide your field into 4. Your nose is the division. Okay, and then you ask the patient to count your fingers. Okay, how many fingers here? Okay, and then how many fingers here? And then how many fingers here? How many fingers here? Okay, you divide it into 4. Okay, before asking the patient to count your fingers, you can always ask the patient, can you see my whole face? Okay, ask the patient to close one eye. You ask the patient, can you see my whole face? Can you see everything? Okay, if patient says, oh yeah, I can see everything, then it gives you a clue already. But if you ask the patient to close one eye, and then the patient says, how come I can only see half of your face? Okay, so that already gives you a rough guide that this patient has some visual field problem. Okay, am I right? Okay, it's very easy. Okay, ask the patient to close one eye, look at your face. Okay, how do you see everything? Oh no, I cannot see half of your face. Okay, so roughly you know that the patient cannot see this side. Okay, and then you ask the patient, you give it into 4 quadrants. You ask the patient, how many fingers? How many fingers? Okay, how many fingers? How many fingers? Okay, all right. So that is the crude way of doing visual field. Okay, the proper way is you must use a moving target. You must use pin with a white top, white top pin. You sit in front of the patient, and then you move the target from outside to the inside. Okay, all right. Okay, perhaps I will get you like this. The target must come from outside, goes to inside, and must cross your midline. Because if the patient have a homonymous field defect, if you don't cross your nose, then you wouldn't know where is the defect is. Or if the patient have a central defect, for example, patient have a macular problem, central defect, unable to see your face. But if you just go from outside, then it's not fair for the patient. That is wrong. You must bring your test pin across the face of the patient. Okay. If I find a good video, I will put it up in the Google Classroom. Okay. It's nice to practice if it's face to face, but in an online condition, it's a bit difficult. All right. So, okay, the white target is just for normal visual field, but you can use the red top pin if you want to use to test the blind spot. All right. If you want to test the blind spot, you must sit in front of patient. Patient look at you straight, and then your top pin, your pin must come from outside until it disappears. Okay. All right. It's easier to test it to do it face to face. Okay. So just all right. I hope we are clear over there. Now we just go on into some terminology that will be used during this visual field testing. Scotomas. What is scotoma? Scotoma is just a reduced or absent vision within an otherwise intact visual field. Okay, it is not necessarily cannot see at all. It can be a little bit blurred, Okay, all right. So because I can give you an example. I have seen a patient who came with, I think, she kept on hitting the object on the right side. Okay, telangga, always telangga. So when we test the visual field, actually she said it's blurry on this side, blurry on this side, but this side is clear. Okay, so and it is equal on the both sides. So when we map it, it was actually bitemporal hemianopia. Okay, it's not that she cannot see, but it's actually a little bit blurred. So that is also considered as a scotoma. All right, so there are a few types of visual field. We have confrontation, where you sit in front of the patient, and you have other machines or like other ways to map the patient's visual field. Okay, if you go to the clinic, you will see this black sheet. This is our visual field of one eye. You close one eye, you focus at the center, you sit at 2 meters in front. Okay, and then the examiner will bring a pin, a white top pin, from outside to inside, following the line. Okay, it is just the same concept of your confrontation visual field. Okay, that is how you should do. You bring your pen outside, cross the midline. You must cross the midline. Okay, you give and from top, from temporal, cross, from nasal, from temporal, inferior, cross, inferior to top, you cross. Okay, and then here, it's all the same concept. Nampak ke? Can you see? Cannot see, can see. Okay, like that. Can you see? No. Can you see? No. Can you see? Can you see? Yes, 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 yes. Until it crosses the midline. Okay. Okay, so this is how they map the Jerem visual field. The B is silent, okay? It's Jerem, not Bejerem, it's Jerem. Okay, this is how they map. This is the right eye of the patient. This is the no, this is the right visual field of the patient. This is the left visual field of the patient. So this blue thing is where patient cannot see. If you see anything like curve like this, it's called arcuate. It's arcuate scotoma. Why is it curved like that? Because it's following the retinal nerve fiber layer pattern. Okay, if one cell is damaged, the whole stretch will be damaged. So that's why it's following the arcuate pattern. Okay, next is Goldman visual field. This is very old, a very old machine. Not many hospital has it anymore. But a patient will sit here, close one eye. The ball will have a blinking light. Okay, blinking light. So if the light shines, the patient will click the machine. Okay, will click the machine. So this is how you map a Goldman. The black thing is your blind spot. Okay, your blind spot. This is if patient cannot see, then you will shade it. Okay, and there's a code to it. All right. And next, the most commonly used now is Humphrey visual field. Humphrey is the name of a guy who invented this. Okay, so in Humphrey visual field, it's the same concept also. The patient sits here, cover one eye. So this is which eye? This is the left eye of the patient. No, the left visual field, not the left eye. The left visual field of the patient, like this. Okay, the left visual field of the patient. This is this is the right visual field of the patient, because this is the blind spot. Okay, this is a patient's nose. This is patient's nose. If you don't know which one, either you remember this or remember that. The second one is always the nose, and this is the blind spot. The blind spot is temporal. Okay, the blind spot is always temporal. Okay, so this one is arcuate scotoma, following the optic. From the optic nerve, it follows the arcuate. Alright, so this is superior arcuate scotoma, and this one is another patient, right visual field, and then the left visual field. So you see this, the black one, patient cannot see. This one, patient can see, patient cannot see, patient can see. So this patient has right bitemporal hemianopia. Okay, right temporal hemianopia. So how does the visual field work? The Humphrey visual field works. It will record the patient response. There will be light blinking inside the bowl, and the light will record. The light will get dimmer and dimmer and dimmer. Okay, so the patient will click once they see it. So the dimmer the light, the more sensitive the eye is. Okay, so and then this one probably even the bright light also patient cannot see. This one dim light patient can see. So that's how finally the computer will map it out. Okay, so these are just the terms: central scotoma, bitemporal hemianopia if the defect is at the chiasm, homonymous hemianopia if the defect is posterior to the chiasm. Okay, apparently the time is running out. I will have to continue with you in the next lecture. Okay, bye. See you.